This is Stephanie Robert, and I'm going to be discussing our chapter, Unusual Gliomas, by Stephanie Robert, Michael DeLuna, Joachim Behring, Robert Fulbright, Anita Hutner, Joseph Pietmeyer, and Jennifer Mullen-Turno.
Unusual gliomas deserve special consideration and classification for improved diagnosis and treatment of these rare pathologies. As our understanding of the molecular and genomic characteristics of tumors evolves, the diagnosis and treatment of central nervous system tumors is expanding beyond histological and immunohistochemical properties into a molecular realm, allowing more targeted treatment. Many of these unusual gliomas present with similar symptoms and are difficult to differentiate based on imaging, emphasizing the necessity of tissue analysis for diagnosis. A more clear and defined understanding and classification of these rare and unique tumors will allow for much-needed improvement in targeted treatment and guide prognosis for patients with these unusual gliomas.
First, we will discuss the algorithm used for the diagnosis and management of unusual gliomas. Patients typically present with either new neurological symptoms or after an event such as incidental trauma, which necessitates head imaging to be acquired. Head imaging in the form of CT or MRI is performed, on which intracranial mass is then identified. Combining this imaging with the patient's symptoms, history, and physical exam findings, a differential diagnosis can be generated. Patient's imaging and other pertinent information is then reviewed at tumor board for multidisciplinary evaluation and management recommendations. If the patients are asymptomatic and the lesion appears to have low-grade features, many of these can be followed expectantly with surveillance imaging. If, however, the patients are symptomatic, there is concern for high-grade features, or previously asymptomatic low-grade appearing lesion becomes symptomatic or develops concerning features on follow-up imaging, surgery is then typically recommended. Surgery allows both the opportunity for tumor resection, as well as, importantly, provides tissue for pathologic and molecular analysis, including whole exome sequencing. The patient's imaging, pathology, and molecular data is then presented at tumor board for further in-depth discussion, at which time adjuvant therapies and precision medicine options can be explored.
The first of these unusual
gliomas we will discuss are the subclinical giant cell astrocytomas, also called SIGAs.
They are classified by the
World Health Organization as a grade 1 glial tumor.
They are almost exclusively
found in young patients with tuberous sclerosis complex, a rare neurocutaneous disorder that results from mutations in either the TSC1 or TSC2 gene, both of which are tumor suppressor genes in the mTOR pathway.
The classic presentation
of tuberous sclerosis is a triad of seizures, mental retardation, and adenoma sebaceum. However, this triad is only seen in about 30% of patients.
Other common findings
include cortical and subependymal tumors, white matter abnormalities, cardiac rhabdomyomas, and tumors of the spleen, kidney, and pancreas. SIGAs affect about 5 to 15% of patients with tuberous sclerosis, with a peak presentation of 8 to 18 years old.
Although typically a
slow-growing tumor with low risk of transformation, they often become symptomatic as a result of obstruction of the ventricular system as these tumors grow.
On MRI, they have
a characteristic appearance with a well-circumscribed, partially calcified, homogeneously enhancing lesion adjacent to the foramen of Monroe.
They enhance
strongly with contrast on both CT and MRI. Interestingly, patients with imaging findings of SIGA may also have cortical lesions called tubers, which are benign hamartomatous lesions and are classic findings in tuberous sclerosis patients. SIGAs receive their name from their periventricular location and their typical pathologic appearance, specifically the presence of giant cells that resemble astrocytes. They are typically well-demarcated tumors with modest infiltration into the surrounding white matter. However, they do expand into the ventricular cavity. Routine histological examination reveals these giant cells with abundant eosinophilic cytoplasm, as well as spindle-shaped cells with eccentric nuclei. Immunohistochemical staining reveals tumors positive for GFAP and S100. In general, these tumors do not necessarily require intervention, given their slow growth. However, they often obstruct the foramen of Monroe, causing symptoms of obstructive hydrocephalus requiring surgical resection. Surgery is not possible, or if hydrocephalus persists after tumor resection, ventricular shunting may be necessary. Although these tumors have low risk of malignant transformation, surveillance is appropriate to monitor growth and/or recurrence.
More recently, pharmacotherapy options are now becoming available for these tumors. Two new drugs, sirolimus, also known as rapamycin, and everolimus, are two new pharmacological therapies targeting the mTOR pathway and have shown some efficacy in halting tumor growth and reducing tumor volume. Unfortunately, many patients with these tumors have symptoms of obstructive hydrocephalus due to the tumor location, which often necessitates surgical resection. However, pharmacological treatment with mTOR inhibitors is becoming more common in specific patient populations and is showing promise as an alternative treatment modality in those patients which surgical resection is not able to be safely performed. Angiocentric gliomas are rare tumors that were first described in 2005 and first introduced into the World Health Organization classification in 2007 as a grade 1 tumor. They are typically found in children and young adults with refractory seizures. Their appearance on imaging is similar to those more common diffuse glial tumors, with MRI demonstrating typically a frontal or temporal cortical lesion with gyral expansion. They spread in the subpial plane and along blood vessels with a stalk that extends to the ventricular surface. CT imaging shows an expansile, non-enhancing cortical lesion, and MRI shows a T1 hypointense, T2 hyperintense lesion with flare signal. Some lesions show a more characteristic cortical rim of T1 hyperintensity, which is highly suggestive of this tumor on MRI. Histologically, angiocentric gliomas appear as monomorphic, spindle-shaped, bipolar cells associated with normal vessels with the cortex and white matter. They have a striking perivascular growth pattern, which is their defining feature. Tumor cells are arranged radially around the central blood vessel, similar to that of ependymal perivascular pseudorosettes. Although mitoses are rare, there is a high prevalence of adjacent cortical dysplasia, which likely explains the high incidence of associated epilepsy. They do demonstrate some parenchymal invasion, however, they maintain a strong preference for perivascular growth and spread. Intralesionally, they have abnormal neurons resembling ganglioglioma cells, as well as cystic regions with myxoid changes. Immunohistochemically, angiocentric gliomas show expression of astrocytic markers S100, GFAP, and vimentin. Some cells have epithelial membrane antigen expression with dot-like staining of microlumens, suggestive of ependymomatous differentiation. Recent data suggests that these tumors carry a mutation in the MYB gene, resulting in mutation of a proto-oncogene. As this mutation has not been commonly found in other glioma subtypes, it may prove to be a marker of these tumors. Angiocentric gliomas demonstrate indolent growth with rare progression, and gross total resection is considered curative. Even, however, after subtotal resection, progression seems to be rare. Gross total resection also provides resolution of seizures without adjuvant therapy required. Astroblastomas are extremely rare tumors that are included in the World Health Organization classification under other gliomas. However, they do not currently have an official assigned grade. Although described in 1930, controversy remains regarding these tumors being a distinct entity, given its rarity and that many of its features can be found in other neoplastic lesions. Furthermore, many tumors exhibit low-grade characteristics, however some do exhibit high-grade features, further distorting its classification and grading. These tumors typically present in the first 3 decades of life. However, those that present later are highly malignant and have a striking female preponderance of 11:1. They have been found to affect the cerebral hemispheres, usually involving the cortex and subcortical or periventricular regions, and rarely have been found in the cerebellum. Patients typically present with symptoms related to cortical dysfunction or mass effect, hemiparesis, seizures, and personality changes. Tumors that have been found to harbor malignant features portend a rapidly fatal course, with evidence of progression to glioblastoma and gliosarcoma. Determining their imaging characteristics has also been limited given their rarity. They appear poorly defined on CT, with findings ranging from a hypodense mass with irregular enhancement pattern to a well-defined lesion with intense enhancement. MRI typically shows a large, well-demarcated, lobulated mass with solid and cystic components and a bubble appearance of the solid component. Frequently, REM enhancement is seen surrounding a cystic center, and calcifications may be present with minimal vasogenic edema. Astroblastomas can be defined macroscopically with their cut surfaces demonstrating homogeneous soft pink-gray substance.
Microscopically, hyalinized blood vessels are seen with clusters of tumor cells forming pseudorosettes. Their nuclei are oval and slightly irregular and contain coarse chromatin nodes with cellular atypia in varying degree, and a high number of mitotic figures, especially in the high-grade variants. Tumor cells usually stain for GFAP and also show bimentin, neuron-specific enolase, S100, and epithelial membrane antigen. Recent studies demonstrate chromosomal aberrations, BRAF mutations, and absence of IDH and TP53 mutations. Optimal treatment protocols are difficult to determine given the rarity of these tumors. However, gross total resection remains the standard of care, and these tumors are typically well circumscribed and in surgically resectable regions. Adjuvant radiation and chemotherapy are typically reserved for higher grade lesions. Unfortunately, recurrence of lower grade lesions after gross total resection is rare.
Pylomyxoid astrocytoma are a common and aggressive variant of pilocytic astrocytomas with unique clinical and histopathological characteristics. Initially included within the pilocytic astrocytoma classification and considered a grade 2 lesion, they are now listed as a separate entity, however have not been assigned a formal grade, as their behavior and pathophysiology needs to be better defined. Pylomyxoid astrocytomas can be found throughout the neuroaxis, however the majority are found in the hypothalamic chiasmatic region. They are more rarely found in the posterior fossa, basal ganglia, parietal and occipital lobes, as well as the spinal cord. The mean age of diagnosis is typically children from 1.5 to 3 years old, and patients typically present with elevated intracranial pressure with symptoms of hydrocephalus or enlarging head circumference. MRI findings are nonspecific, demonstrate well-circumscribed, non-infiltrating lesions without surrounding vasogenic edema. Lesions are hyperintense on T2-weighted sequences and demonstrate flare signal with heterogeneous to homogeneous enhancement, and a quarter of these tumors may demonstrate intralesional hemorrhage as well.
Histologically, pylomyxoid astrocytomas consist of monomorphic spindle bipolar cells in a loose papillary and myxoid background. Cells are arranged in an angiocentric pattern radially around vessels. However, they lack the biphasic architecture with Rosenthal fibers and eosinophilic granular bodies that are commonly found in pilocytic astrocytomas. Mitotic figures are rare, and Ki67 expression is often low. However, it is typically higher than that of pilocytics. Immunohistochemical staining demonstrates GFAP, S100, and bimentin with scattered P53 staining. There does appear to be an overlap in the molecular characterization of pylomyxoid and pilocytic astrocytomas, and some studies even suggest that pylomyxoids may transform into pilocytics. Generally, these tumors are managed with surgical resection if the location of the tumor allows. Adjuvant chemo and radiotherapy is evolving, with literature favoring paradigms similar to those for low-grade astrocytomas, with indications for these adjuvant therapies for tumor recurrence or subtotal resection. Some studies are suggesting that bevacizumab may also be a useful adjuvant therapy. However, more research is needed to establish a treatment protocol for these tumors. Overall survival times are reported to be significantly lower for pylomyxoid compared to pilocytic astrocytoma. However, much of this reduced survival is attributed to the inoperable location of many of these tumors, preventing gross total resection. Pleomorphic xanthoastrocytomas are classified by the World Health Organization as a grade 2 tumor. Most commonly located in the temporal lobe, patients often present with seizures and chronic temporal lobe epilepsy. They have also been reported in the cerebellum and spinal cord and can present with headache, focal location-related deficits, and elevated intracranial pressure. Rarely, patients may present with symptomatic hemorrhage. These tumors are found in young patients around age 20 to 30 years old and are typically slow-growing lesions. However, an anaplastic subtype of these tumors has been defined and are classified as a WHO grade 3 tumor, and patients can experience rapid growth even despite adjuvant therapy in some cases. On imaging, CT and MRI show a cortical cystic structure with enhancing neural nodule. Well-defined contrast enhancement of the tumor mass or nodule is often seen on CT and is uniformly present on gadolinium-enhanced MRI. Leptomeningeal enhancement and dissemination has also been reported. Calcifications are rare, and mild to moderate amounts of peritumoral edema may be seen. If peritumoral edema is present, this may be a sign of poor prognosis for these tumors. Pleomorphic xanthoastrocytomas are firm, relatively avascular tumors. They typically invade the pia arachnoid space, but rarely invade the underlying brain. The associated cyst contains xanthochromic fluid and is located close to the meninges, with more prominent mesenchymal features compared to the glial features found near the interior of these lesions. Specific microscopic criteria exist for the diagnosis. Criteria include presence of pleomorphic and xanthomatous astrocytes, perivascular lymphocytes, eosinophilic granular bodies, a non-infiltrating histology, and reticulin staining. Characteristically, spindle cells with elongated nuclei are seen in streaming or storiform patterns, and in other areas, round or polygonal cells can be found with ground glass eosinophilic cytoplasm containing pleomorphic and occasionally multiple nuclei. Cells may contain variable amounts of hyaline protein and lipid droplets, and these lipid-laden cells with scant cytoplasm that are characteristic. Mitotic figures are usually absent. However, a subset of tumors have been found to have significant mitotic activity, and these are now designated as anaplastic pleomorphic xanthoastrocytomas, and are defined as a more malignant grade 3 tumor. Immunohistochemical staining reveals the spindle cells and most of the round pleomorphic cells are positive for GFAP and S100. The presence of GFAP in the spindle cells differentiates these tumors from other lesions such as fibrous histiocytomas, fibrous xanthomas, meningiomas, and other primarily sarcomatous tumors. Genetic studies have also identified BRAF mutations in these tumors. Surgical resection is associated with a favorable outcome. However, local recurrence and malignant transformation can occur, arguing for continued surveillance even after gross total resection. Adjuvant therapy is typically recommended to be reserved for disease progression or recurrence. Gangliogliomas are classified by the World Health Organization as a grade 1 tumor. Up to 85% of these tumors occur in the temporal lobe and are associated with temporal lobe epilepsy. They have also been described in the spinal cord, brainstem, and cerebellum. Presentation is usually in children and young adults with a slight male predominance. Although more rare, an anaplastic subtype of gangliogliomas may occur, and these lesions represent a more malignant phenotype and are classified as a WHO grade 3 tumor. Gangliogliomas display highly variable characteristics on imaging, with up to half containing both cystic and solid components, and some either entirely solid or entirely cystic. The degree of contrast enhancement is also variable, and peritumoral edema is rare. Higher grade subtypes, however, tend to have greater and more consistent contrast enhancement with marked surrounding edema. Both FDG PET and SPECT imaging have been found helpful to differentiate grade 1 and grade 3 lesions prior to surgical resection. Gangliogliomas contain both neuronal and glial elements, although they vary considerably as to the proportion of each component present. However, the grade of the glial component determines the overall tumor's behavior. Rosenthal fibers and eosinophilic granular bodies may be encountered in more cellular tumors. Immunohistochemical staining show both glial markers, consisting of GFAP, S100, and vimentin, and neuronal markers such as synaptophysin. Mitotic figures are rare in gangliogliomas. However, the anaplastic subtype demonstrate malignant transformation of the glial component and demonstrate high mitotic labeling with Ki67. The neurons are large and polygonal, with prominent nucleoli, sparsely distributed chromatin, and nuclear membrane enfoldings. Gross total resection is the preferred treatment for these tumors, and seizure control can be as high as 80% after resection. Adjuvant therapy, specifically radiation, is typically recommended as an adjuvant or salvage treatment for residual or recurrent tumors. Papillary tumor of the pineal region is a relatively new addition to the World Health Organization classification and is considered a grade 2 or 3 lesion. They present across a large age range, most commonly around middle age, and both in men and women. As with most pineal lesions, patients present with headache, mental status changes, hydrocephalus, and vision changes. These tumors are diffusely contrast-enhancing masses in the pineal region and posterior third ventricle, They are often accompanied by hydrocephalus on presentation due to their location. Newer findings suggest intrinsic T1 hyperintensity on MRI may be common to these lesions. However, they otherwise have a similar appearance to many other tumors located in this area. These tumors contain eosinophilic cells with indistinct borders and large pleomorphic nuclei without necrosis or vascular proliferation. They derive their name from their pathological appearance, consisting of papillary features, rosettes, and pseudorosettes. Tumor cells are positive for cytokeratin and synaptophysin, and also stained for GFAP, vimentin, S100, and neuron-specific enolase. The optimal treatment of papillary tumor of the pineal region appears to be surgery. However, local recurrence is possible, and radiotherapy may be beneficial as an adjuvant therapy and also for subtotal resections. Dysembryoplastic neuroepithelial tumors, also called DNETs, or WHO Grade 1 tumors. They most often occur in the temporal lobe and are found in young adults with long-standing treatment-resistant epilepsy. Interestingly, they exhibit similarities to oligodendrogliomas, and many were likely misclassified as such prior to their officially being described as a separate entity. Although over 65% of these tumors are located in the temporal lobe, they have been found in a variety of locations, typically supratentorially. MRI demonstrates a cortically based lesion that expands a gyrus, and due to its typically long-standing presence, may show thinning of the inner table of the skull. MRI enhancement is variable, and calcification is common. T2 sequences on MRI may show bubbly appearance, and FLAIR sequence shows mixed signal intensity with bright rim signal that on pathological exam has been found to be created by glioneuronal elements packed along the tumor margin. Interestingly, there is a characteristic lack of mass effect within these lesions. They are also typically stable radiographically for long periods of time. DNETs have a characteristic appearance marked by a specific glioneuronal element which describes the columnar organization of neuronal axons draped by small oligodendroglioma-like cells. This pattern results in nodular organization of the tumor within the cortex. Stellate astrocytes are positive for GFAP, and oligodendrocyte-like cells are S100 and OLIG2 positive. Synaptophysin is diffusely present in the neuronal elements of the tumor. They have low mitotic activity and do not demonstrate 1p19q deletions. Focal dysplasia is commonly seen associated with DNETs, suggesting the dysembryoplastic origin of these tumors. DNETs are indolent tumors with minimal growth over time. However, they often cause chronic refractory epilepsy, and therefore surgical resection is favored. Surgery provides favorable long-term seizure control. Choroid glioma of the third ventricle were officially recognized in 1998 after the publication of several cases with similar clinical, radiological, and pathological findings. They are now classified as a WHO Grade 2 tumor. They are slow-growing lesions that arise in the anterior wall or roof of the third ventricle. Patients typically present with symptoms of obstructive hydrocephalus, and they can cause visual loss and pituitary and hypothalamic dysfunction. Although they have been described in a wide range of patients, most present in adults with a female predilection. Choroid gliomas are well-circumscribed lesions, often filling the third ventricle, causing obstruction of the lateral ventricles. They have diffuse contrast enhancement and typically have a hypothalamic component that does not appear infiltrative. Choroid gliomas consist of clusters of oval epithelioid cells found in a mucinous stroma and show positivity for GFAP, vimentin, CD43, and TTF1. They are thought to arise from the epinemal cells of the lamina terminalis, specifically from tanocytes, a type of epinemal cell. Surgical management of these tumors is preferred, however, resection is often limited by location. The usefulness of adjuvant radiotherapy remains undetermined, however, radiosurgery may offer some benefit. If tumor resection is not possible or obstructive hydrocephalus remains postoperatively, a ventricular shunt or endoscopic third ventriculostomy may be necessary. Papillary glioneuronal tumors were initially considered a variant of ganglioglioma until 1998 when they were introduced as a distinct entity, being classified as WHO Grade 1 lesion. They typically present in adolescent patients, however can be seen in young children and the elderly. Most lesions are asymptomatic,
However, when patients become symptomatic, they typically present with headache or seizures, especially when the lesions are located in the temporal lobe. On imaging, these tumors are well demarcated, often periventricular cortical lesions. They can demonstrate cystic degeneration, frequently contain calcifications, and the solid component typically shows intense but heterogeneous contrast enhancement. These tumors often resemble other lesions, especially gangliogliomas. Papillary glioneuronal tumors have a characteristic biphasic morphology consisting of glial and neuronal components, with the glial component being astrocytic and the neuronal component demonstrating extensive differentiation that includes neurocytes and ganglion cells. The neuronal differentiation corresponds to their indolent course. Areas of focal necrosis and angiomatous changes are also present. Prominent vasculature may be present and typically contain a pseudopapillary component with intervening neuronal elements present in sheets of cells. The perivascular arrangement of cuboidal GFAP-positive astrocytes is not seen in glioneuronal neoplasms, and therefore the architectural pseudopapillae is the most distinctive feature. Immunohistochemical staining shows glial cells positive for GFAP, nestin, and S100, and the neuronal component stained for synaptophysin, neuron-specific enolase, and class III beta-tubulin. Fibroblast growth factor receptor mutations have been described, as well as PTEN loss and MGMT methylation. As indolent tumors, they have a favorable prognosis, and resection typically provides long-term control. One of the newest entities to be described in the World Health Organization classification of tumors is the diffuse leptomeningeal glioneuronal tumor, a rare etiology known in the literature most commonly as disseminated oligodendroglial-like leptomeningeal tumor of childhood. No grade has been assigned by the WHO yet, however, it does have a low-grade histological appearance. The lesion appears as prominent leptomeningeal enhancement, typically without an identifiable solid component. They have a male predominance and are most often found in children less than 18 years old. Patients most commonly present with hydrocephalus due to the tumor cells present in the subarachnoid space. Some patients may present with focal neurological symptoms, including cranial nerve impairments or seizures. The characteristic imaging feature of these tumors is thick nodular enhancement of the leptomeninges. The enhancement is most apparent around the basal cisterns and surface of the brain and spinal cord. While there may be small enhancing intraparenchymal lesions, there is a lack of a dominant parenchymal mass in imaging. Small subpial cysts may also be seen over the surface of the brain and the spinal cord. Diffuse leptomeningeal glioneuronal tumors consist of cells with round to oval nuclei, perinuclear rings, and cytoplasmic swelling intermixed with desmoplastic fibrous response. They have similar appearance to oligodendroglia, and they also demonstrate chromosome R1p deletions, co-deletion of 19q, however they do not show IDH mutations. They typically harbor BRAF fusions, and some have reactivity for OLF2, MAP2, S100, and GFAP. Given that this is a newly defined entity, survival and prognosis remains unclear. The lesions appear to be slow-growing, however, patients can have significant morbidity due to secondary hydrocephalus. Unusual gliomas are rare and unique pathologies that deserve special attention and consideration during evaluation of new intracranial lesions. Although many have an indolent course, they are often associated with significant symptoms, including hydrocephalus and epilepsy. Imaging alone is rarely sufficient to establish a diagnosis of these tumors, and careful attention must be paid to the pathologic, histochemical, and molecular characterization of these lesions for determination of appropriate management and treatment. As central nervous system tumors are becoming increasingly understood and defined through molecular characterization, our understanding of their underlying pathophysiology will continue to improve and allow for more targeted treatment and precision medicine for these patients.